Francesca. Monica is a full member at the St. Jude's Children's Research Hospital. She did her undergraduate and graduate studies in Aachen, Germany, and has specific interest in lymphoreticular malignancies, but also Monica has another life. She focuses on St. Jude, on Hodgkin's disease, but is the director of the Central and South America St. Jude's global efforts, and has been very effective in describing tools to cure children within specific limitations, the availability of therapy and diagnostics. I hope I said this accurately.
Thank you very much for this very kind introduction. Thank you to the chairs of this session, and thank you to the organizing committee for having me here again for one of the last talks of the symposium. So, again, I am charged with giving you a presentation on something for which there is really very, very little data, but I will try to do my best on that. As you know, Hodgkin lymphoma is a B-cell derived malignancy that is CD30 positive, and as you can see, it is the Hodgkin-Ridge-Sternberg cells are only about 1% of the cells, and then in this slide you see that the Hodgkin-Ridge-Sternberg cells often will be surrounded by these T-cell rosettes. And this is important to understand that the Hodgkin lymphoma, Hodgkin-Ridge-Sternberg cells have a lot of interaction with the microenvironment and is activated through the NF-κB pathway. And one of the targets is the CD30 receptor, for which we are going to now discuss the brentuximab vedotin, which is an antibody-drug conjugate with MMAE, and when this drug attaches to the CD30, it gets it goes through endocytosis by clathrin, and then is released into the lysosomes inside the cell, where the MMAE is cleaved from the drug. The MMAE then potently disrupts the microtubule polymerization, but some of the MMAE also just diffuses through the cytoplasmic membrane and is therefore able to kill bystander cells. So it does not only have an effect inside the Hodgkin-Ridge-Sternberg cell, but also with some of the kills also some of the bystander cells. So, brentuximab vedotin was first published in 2012 in the pivotal trial, and in this trial, the eligibility criteria were relapsed or refractory Hodgkin lymphoma after high-dose chemotherapy and autologous stem cell transplant. It had to have histologically documented CD30 positive Hodgkin-Ridge-Sternberg cells. It was available for children aged 12 years and older, and the patients had to have measurable disease of at least 1.5 centimeters and show PET ability. And the patients needed echo performance status score of 0 or 1, and then you had to have adequate counts and organ function. The way this trial was performed is patients were given 1.8 milligrams per kilogram by IV infusion every 3 weeks, and the patient characteristics, the median age of 31, with the youngest being 15. 47% of the patients were male, 87% were white, 34% had B symptoms, 8% bone marrow involvement, 66 had received prior radiation, 71% were primary refractory, and the median time from autologous stem cell transplant to relapse was 6.7 months. So what I want to show you here is that there was a significant and very impressive response of a complete response of 34% and a partial remission of 40%. However, the way this, and this is very important in any of these papers looking at efficacy of a new drug, is how do you define response? because how do you define response has undergone a significant shift over time, and depending on, particularly in this trial, it was according to the Chesson criteria of 2007. So in order to be a CR, you had to have your disease had to be less than the surrounding background, had to be avid. So it was a very conservative type of measurement. And if you want to compare how ICE does, for instance, but in the era where ICE was used for salvage of Hodgkin lymphoma, the response criteria were CT-based only and maybe gallium, but not PET. So when comparing the outcome, unless it is a head-to-head comparison, and it is very difficult to compare, because the way each paper or each study group defines their response will definitely vary. And so in this trial, you see this waterfall plot, and when looking at the tumor decrease size, there was a significant decrease in size. Even a couple of patients had disappearance of their disease. And then the blue means that it is in CR by PET, but by this very conservative definition of PET. So probably I would say the response, if we were to look today on these patients, we would have considered more patients to be in CR than the authors did at that point. So then I want to tell you about my patient GH. He was diagnosed with Hodgkin lymphoma around the same time that this trial was running. He had lymphocyte-depleted Hodgkin lymphoma. He was stage 2BE with extension to the pericardium, and his sites of disease were left leg, mediastinum, and left hilum, and the extension to the pericardium. He was diagnosed in September of 2009, and at the time we gave Stanford 5 chemotherapy. That was our protocol. And he got left neck, mediastinum, left hilum, and pericardial radiation. Chemotherapy in January of 2010. Unfortunately, 6 months later, this was his PET scan. So he had significant relapse with, this time, left neck, mediastinum, and bilateral lungs. What did I give him? Anything I could find. I gave him 2 cycles of GV, and I always give only 2 cycles of whatever I do, because unless the patient is responding, there is no reason to continue doing something that is not working. So after 2 cycles of GV, he only had a partial response. I wasn't happy, so I switched to ifosfamide, gemcitabine, vinorelbine, and dexamethasone. He still had a partial response, but it wasn't gone, so I switched to 2 cycles of DHAP. And then he progressed. He progressed to the mediastinum and bilateral lungs, so I was getting discouraged. I gave 2 cycles of MIA, that's high-dose methotrexate with ifosfamide, etoposide, and dexamethasone, and this is high-dose methotrexate at 8 grams, so it's very high dose. He had a partial response, but it wasn't gone. At this point, the transplanters had already told me that they will not transplant him. So I was able to convince them, okay, if not an autologous, because by now his bone marrow reserve was getting poor, to do an allogeneic bone marrow transplant. They said they would not transplant him. I gave him bendamustine. He progressed again. So, and as I showed you from before, the pivotal trial on brentuximab vedotin, even though did not make him eligible because he didn't have a transplant. So I wanted the transplanters, just please transplant him to make him eligible for trial, and they wouldn't do it. By then, the pivotal trial then closed, but it was still open for compassionate use, but according to the same eligibility criteria. I was able to convince the pharmaceutical company to change the eligibility criteria because it didn't make sense that a patient like mine wouldn't be eligible. So they actually changed it, and I was able to get him to Texas, to Texas Children, to get brentuximab vedotin. But before that, while I was negotiating all this, we gave him radiation to the mediastinum, 33.6 gray, and then he had a PR. And then at the end, I just did something that is not standard of care in Hodgkin lymphoma. I did a surgical removal of partial of the mediastinal mass that was still pit-avid, and some of the pulmonary extension. So I mean, I was incredibly radical, and then he started his brentuximab vedotin. So he received a total of 2 years of brentuximab vedotin every 3 years. Why 2 years? Because there was no evidence. At this point, I wasn't going to take him to transplant. He knew he was high risk of relapsing. We didn't know when to stop. There was not enough data on that. But I can tell you that he is now in remission for 6.5 years. He's suffering from significant complications of all the radiation, and he's got some pulmonary, restricted pulmonary disease, but he's alive and well. This is a case report, certainly. This is not what anybody should be doing, but I am just telling you, as these trials started to come up, this is a patient who would hopefully today would have received a transplant, and I would have consolidated him. So then the ETHERA trial, or the brentuximab vedotin trial for consolidation after stem cell transplant, was published in The Lancet in 2015. For this trial, the eligibility criteria were ages greater than 18, histologically confirmed classical Hodgkin lymphoma, status post-high dose therapy and autologous stem cell transplantation, and eligible patients had to have at least one of the following risk factors: either primary refractory Hodgkin lymphoma, meaning failure to achieve complete remission. So already you see for this trial, it wasn't, they didn't have to have had, anyhow, well, this was after their autologous stem cell transplant. They relapsed in an initial, they had to have a short remission, less than 12 months, and extranodal involvement at the start of pre-transplantation salvage therapy. So just one of these high-risk factors had to be present. And they had to have chemosensitive disease, or at least non-progressive disease before transplant, so CR, PR, or stable disease before going to transplant, and adequate organ function, and they must not have received previous brentuximab vedotin. So they randomly assigned 329 patients to either BV or placebo. The median age was 33, and 46% were male, 93% were white, and the number of previous Hodgkin lymphoma therapies were more than 2 in 43% of the patients. The best response to salvage therapy was CR in 37%, and it was PET positive prior to transplant in 34% of patients, and 33% of patients had extranodal involvement prior to transplant, and 28% had B symptoms after frontline therapy. So this is the curve with a median progression-free survival by the independent review of 42.9 months versus 24 months only for those that received placebo. So it was definitely statistically significant that these patients had an improved progression-free survival. Though when you look at the overall survival, there was no difference between both. And who was most to benefit from this maintenance therapy? It was patients who had a partial remission at the time of transplant, patients who had either refractory disease or a very short interval between to relapse, and patients that were younger, patients that had more than 2 systemic therapies before transplant, and patients that had B symptoms, and patients that had extranodal disease. So then we started using brentuximab vedotin for maintenance therapy in some of our patients. And we recently published this experience in Pediatric Blood and Cancer in last year, where we have 5 patients for which we used brentuximab vedotin as maintenance therapy. And I'm going to tell you about this young lady. 16-year-old patient at diagnosis who at age 17 went on to get BV maintenance. How was her case? So SR presented to the local ER at the age of 16 for swelling of her neck and had no quantified fevers, though when we saw her, because she was admitted to the hospital, she did have fevers. And she had biopsy-confirmed Hodgkin lymphoma. This is her PET scan at presentation. And as you can see, she had a significant mediastinal disease and left supraclavicular disease as well. She was a stage 2B. Now, as I told you, the risk classification is very tied to the protocol that you use. For our protocols, stage 2B is high risk. For many other protocols, like for the Euronet, it is intermediate risk, and for the COG, it would be intermediate risk. But the way we defined our high risk cohort, this patient is high risk. And we had a high risk protocol open at the time, which was the HLHR13, so she was one of our earlier patients, and she got 2 cycles of AIPA and 4 cycles of Capdac. So that's like OIPA Capdac, only that instead of giving vincristine, we give brentuximab vedotin. She had an excellent response. As you can see, after 2 cycles, she had a metabolic response. Now again, every protocol follows their own rules, and in our rules for this protocol, it was not only necessary to have be PET negative, but also have at least a 75% reduction of the mass at the time of early response to qualify for no radiation. And as you can see, she did have